Welcome to this explainer. Today, we're stepping right into a busy clinical shift. Whether you're a medical doctor, a nurse, a clinical officer, or an emergency practitioner, you know that headache is one of the most common and honestly potentially terrifying chief complaints you're going to face. So we're going to build a really practical, evidence-based framework for evaluating and managing adult headache disorders. We're covering the whole shebang, from pathophysiology and structured history taking all the way to distinguishing a benign tension headache from a life-threatening hemorrhage. Let's dive in.
Here's our roadmap for the shift. We'll start with the clinical challenge, move into catching red flags, profile primary headaches, unmask the secondary ones, and finally, unpack our diagnostic toolkit.
Section 1. The Clinical Challenge, Finding the Needle in the Haystack.
So, with over a 90% lifetime prevalence in the general population, the vast majority of headaches you evaluate are going to be completely benign. But your ultimate clinical challenge, the real reason we're all here, is finding those dangerous outliers. You know, the secondary headache that signals an impending disaster like a stroke, an infection, or a hemorrhage. This initial management algorithm is basically your baseline for every single headache patient you see. You always start with the vitals, right? A fever or extreme hypertension immediately changes your triage path. Then you do a focused history and a comprehensive neuro exam, paying really close attention to cranial nerves, motor function, and gait. Next, you run their presentation against specific red flags, which will ultimately dictate your neuroimaging and diagnostic decisions.
Okay, moving to Section 2, Catching Those Red Flags with the SNOOP 10 Framework.
To act as a safe triage filter without missing a beat, we rely heavily on the SNOOP 10 framework. This mnemonic is an absolute lifesaver because it efficiently prioritizes the highest yield warning signs that require your immediate attention. S stands for systemic symptoms, think fever or meningiismus. N is for neoplasm history or neurologic deficits like a sudden hemiparesis. O covers sudden onset or older age, and actually let me emphasize that. A brand new headache in someone over 50 is a huge red flag for malignancy or giant cell arteritis. Finally, the P's cover things like pattern changes, positional pain, or papilledema. If your patient hits any of these criteria, they get fast-tracked straight to the high-risk category.
Let's really zero in on one specific O, sudden onset, the notorious thunderclap headache. This presentation is a massive, blinking red flag. By definition, it's a severe headache that reaches its maximal intensity within just 1 minute. Its explosive, unexpected nature is a classic harbinger of a ruptured aneurysm causing a subarachnoid hemorrhage or maybe a reversible cerebral vasoconstriction syndrome. If a patient tells you it felt like they were literally struck by lightning in their head, no questions asked, you move immediately to emergent imaging.
Section 3. Profiling Primary Headaches, the Benign Majority. Now, if the vitals are perfectly stable, the neuroexam is completely clean, and the SNOOP 10 red flags are nowhere to be found, we transition to profiling primary headaches. These are the disorders not caused by some underlying structural etiology. Let's run through some rapid-fire clinical cases to get our reps in. Picture this in your clinic. A 35-year-old woman comes in. She's actively seeking out a dark, quiet room. She reports severe, unilateral, pulsating head pain that gets way worse if she tries to walk up the stairs, and she is profoundly nauseous. So what's your diagnosis?
If you guessed migraine, you hit the nail on the head. Our case was a classic migraine, which is driven by the trigeminovascular system, presenting with that severe, unilateral throbbing and intense autonomic sensitivities. On the flip side, you have the tension headache. Tension headaches are honestly rather featureless. It's just that tight, bilateral, band-like pressure without the nausea or extreme light sensitivities. For acute management, tension headaches often respond nicely to simple NSAIDs, while your migraine patients might need targeted therapies like triptans to actually break the cycle.
Let's move to another rapid-fire case that highlights a very specific and frankly agonizing primary headache syndrome. A 45-year-old man presents to you and he is pacing your exam room. He's got excruciating, sharp pain right behind his left eye. He says it lasts about 45 minutes at a time. You notice his left eye is actively tearing, his pupil's a bit constricted, and his nose is running on that same side. What's the diagnosis here?
Right. This is a cluster headache, a classic trigeminal autonomic cephalalgia. And the crucial point you need to take away here is the patient's behavior. While your migraineurs retreat to a dark, quiet room and act like vampires, cluster headache patients are overwhelmingly restless. They will literally pace a hole in your exam room floor during an attack because of that intense cranial autonomic response. If you see this presentation, acute management is going to involve high-flow 100% oxygen and subcutaneous sumatriptan.
Section 4. Unmasking Secondary Headaches, the Life-Threatening Causes.
Okay, now we have to shift gears back to unmasking the secondary headaches. These are the instances where head pain is merely a symptom of a much more dangerous underlying pathology. Paying attention to specific clinical risk factors can instantly unmask a life-threatening condition. For example, if your patient is elderly, on blood thinners, and presents with a dull pain and new confusion, you absolutely must rule out a subdural hematoma. What if your patient is over 50, complains of temporal pain, and says their jaw hurts when they chew? You're likely looking at giant cell arteritis, which, remember, can cause permanent blindness if you don't jump on systemic steroids quickly. And of course, thunderclap onset with meningismus points straight to a subarachnoid hemorrhage.
Now, sometimes you'll encounter a really tricky clinical scenario where the patient's own treatment actually becomes the driver of the pain. We're talking about medication-overuse headache. When patients take acute medications, like triptans, combination analgesics, or opioids, for more than 10 to 15 days a month, their brain receptors adapt. This causes a paradoxical rebound headache. The treatment here is tough but necessary. It requires careful patient education and gradually withdrawing that offending medication, all while bridging them with appropriate preventive therapies.
You also have to keep a high index of suspicion for a few other sneaky, high-risk conditions. If a patient has a fever and a stiff neck, think meningitis and isolate them immediately. If they complain of a severe headache, eye pain, and seeing halos around the lights in your ER, that is not a migraine. That could be acute angle closure glaucoma, and you need an ophthalmology consult stat. And if they have a headache that miraculously vanishes when they lie flat but roars back the second they stand up, you're dealing with spontaneous intracranial hypotension, very often from a CSF leak.
Section 5. The Diagnostic Toolkit, Imaging and Investigations.
Once your history trips one of those SNOOP 10 red flags, it's time to deploy your diagnostic toolkit. But you know we can't just order every test for every patient. You have to know exactly what you're hunting for. Your choice of imaging depends entirely on diagnostic urgency. Reach for the non-contrast head CT in your emergent settings. It's fast, it's right down the hall, and it is highly sensitive for acute bleeding or massive trauma. But if you have a patient with chronic, progressive symptom changes, or you're suspecting a brain tumor, a venous thrombosis, or maybe MS, rely on the MRI. It has no radiation and gives you far superior detail of the brain parenchyma.
Now, sometimes imaging alone just doesn't give you the whole picture, and that's when a lumbar puncture becomes indispensable. You'll perform an LP to measure the opening pressure if you're suspecting idiopathic intracranial hypertension. Even more importantly, you need to analyze that cerebrospinal fluid. Suspect meningitis, you need the CSF for white blood cell counts and protein. And this is absolutely crucial. If a patient has a classic thunderclap headache, but their CT scan comes back completely normal, you must do an LP to check for red blood cells or xanthochromia to definitively rule out a subarachnoid hemorrhage. You cannot skip that step.
Beyond neuroimaging and LPs, targeted disease-specific tests are your final puzzle pieces to confirm those secondary diagnoses. We're checking inflammatory markers like ESR and CRP, followed by a temporal artery biopsy when we suspect giant cell arteritis. We're drawing carboxyhemoglobin levels if a whole family comes in complaining of headaches during a winter cold snap, right? Think carbon monoxide poisoning. And we're using tonometry to check intraocular pressure for suspected glaucoma. It is all about pairing your specific clinical suspicion with the exact right tool. So as we wrap up this clinical overview, I want to leave you with a thought. In your next busy shift, are you going to catch that one dangerous secondary headache hiding among the 99 benign primary ones? By rigorously applying the SNOOP 10 framework, trusting your structured clinical profiling, and utilizing your diagnostic toolkit wisely, you are absolutely equipped to make that life-saving distinction every single time. Thank you for joining me on this explainer, and I'll see you on the next shift.